Hello, welcome to Caldwell County Today. I'm Paige Counts, Public Information Officer for Caldwell County. Today I have a majority of EMS, not really. I have EMS joining me to talk about community paramedic and some new leadership with EMS. Let me have them introduce themselves. Blake, we'll start with you.
Hey, I'm Blake Cochran. I've been with Caldwell County Emergency Services for almost 11 years. Recently took the new position of Caldwell County Training Coordinator. Just looking at progressing the agency and training in different ways throughout the community and community outreach.
I'm Jonathan Cook. I just recently took the new EMS Division Chief's position. I've been with the county for 11 years now.
Tara?
I'm Tara Swanson. I've been with the agency since 2006. Recently in February, I stepped into a new position as a community paramedic.
My name is Jason Powell. I've been with the county for 5 years. I am one of the community paramedics.
My name is Sierra White. I've been with the county for 5 years, and I just recently accepted the alternate CP position. I'm a paramedic still on shift, but I'm doing the alternate position as well.
Okay, we'll get to the community paramedics in just a minute. Jonathan took over as EMS chief fairly recently. Congratulations on your new position.
Thank you.
And as the new chief, what are some of your goals?
Some of our goals is just to continue our overall excellent patient care. We are overall one of the more progressive agencies around us and probably one of the top in the state. We've been recognized as one of the top in the state, especially with our cardiac arrest save rate. We were actually awarded as the #1 overall ROSC award, which is return of spontaneous circulation. So if a patient is in cardiac arrest in the field and get a pulse back in the field, we had a very high statistical rate for that last year. We're still waiting on those stats to come out this year, though. So if we continue on, strive to continue to get the best equipment around, which we already have top-notch equipment. We've got great ambulances. Just continue on where it was left off with Chief Anderson before he retired. Just continue on the agency that him and Chief DiBernardi have performed. Right.
And your staff has been very busy over the last year with COVID. I know you weren't chief the entire time, but what do you have to say about your staff and their work through the last year with COVID and all the extra calls and extra duties they've taken on?
Our staff's been phenomenal. We couldn't have asked for anything better. They've never complained one time. We've never heard anything from them. If we tell them to do something or we ask them to do something, there's never any kickback or feedback from them. They just go and do it. They've been through a tremendous amount. The amount of decons they've gone through, we would actually have to go out and decon their ambulance and them after any time they transported a COVID patient. And like I said, we couldn't have asked for anything better. There was no complaints. They did their job. They provided excellent patient care. And they got the patients to where they needed to go, which was ultimately to the hospital for a higher level of care.
Thank you. And when you were named chief, that left your position as training coordinator open, and Blake Cochran took that position. Blake, congratulations on your new position.
Thank you.
And as training coordinator, what are some of your goals for the agency?
I want to get more geared toward community outreach. That was a big passion to me when I was a CP before. So I want to continue on that track, kind of get more community outreach involvement for CPR, just different areas, stop the bleed with all the school systems in the county. Just anything that we can promote out there in the community, kind of get a lot more community outreach going. So we're looking at adding point of care ultrasound, which for us will be more definitive care and cardiac arrest. We can look at heart activity and tell if they don't have it or they do have it. So that helps us with ROSC saves, taking them to the hospital on their side. We're looking at adding ISAT machines, which will be really good for lab values in the field. So we'll be hurdling that too. We're just totally progressing on that side, staying really involved on the progressing side of the agency, which we haven't in the past. I mean, we're really excelling in that side.
So if a community group wants to reach out to you for a program, how do they do that?
They can reach me at bcochran@caldwellcountync.org, or they can call the office and just ask for me, Blake Cochran, and I'll be happy to get with them and we can schedule whatever they need, fit their needs.
Okay, thank you, guys. Now I'm going to move to probably where we're going to spend most of our time today is our community paramedic program. And I'm going to throw it to all three of them and whoever can answer. What is community paramedicine?
So I guess I'll take that.
Yeah.
I've been here in the position the longest. So our community paramedic program, ours specifically, we're looking to help our current 911 operations. We focus mostly on high utilizers of 911. We see them, we identify them, we get crew referrals. And so we're able to go out and fill the gaps. That's what the analogy that we use when we go out and introduce ourselves to folks, that we fill the gaps in healthcare, whatever that may be. We're able to follow up with chronic disease management. We can help educate folks. We can help them with medication reconciliations. We do home assessments for safety. What we do is fill the gaps, whatever that may be, and whatever we can identify. Not only that, we do supply adjunct support for the 911 operation when we're on duty, so we do still respond to 911 calls, geographically located, and for 911 redirects, and that's really a great area that we've been focusing on. What we mean by a redirect is if a 911 call comes out and myself, Tara, or Sierra are able to take that call and handle it on our own, as opposed to sending two paramedics, an ambulance, and to take them out of service for a potentially higher acuity call that could come out where we can go and help and lift assist or a large portion of that. We have a whole gamut, a whole list of calls that we try and take away from the crews as we're available. But we're there to help follow up after the calls.
And I think it's important to note that you are all three paramedics.
Yes.
I mean, that is your training, so I do want to point that out, is you're not any less than the people on the trucks. You have the same training, probably some more training in some cases in this field. So I do want to point that out. How long has this program been going on?
So the program has been live since July 1st. Blake and myself, we were the first two community paramedics, and we came off the truck almost a calendar year ago, but we went live July 1st. So granted, we've been at it for about a year, actually live with our program and actively seeing patients and identifying them. It's been since July 1st of 2020.
And initially, I'm going to pick on you, Jason, still. You had to develop medical software, what we refer to as EMR, for record keeping. There was a lot put into those first few months of this program.
There was.
Talk to a little bit about that.
Yes, that's, and I think when Tara came on board, she caught it about the second day of the aha look of, okay, this is really, it's ours to create and to build. But yes, those first few months when Blake and I came off of the truck from April until July, we were developing our SOGs. We were developing protocols that had to be approved by the state medical director. We had to figure out which software system we were going to use to document, because the 911 software that we use it's not the same. We don't do the same type of calls. We're upwards of 2-3 hours with clients. So there was a lot of development. We were able to lean on other counties. McDowell, that's the one that we've kind of molded our program after and are looking to continue to do that. We've reached out with state, the rural health has been exceptionally helpful to us. We're kind of picking and choosing from different agencies and what they have, and to kind of mold it to make it our Caldwell way. So we're in the crawling process now. So you're
in the crawling process, but you are making an impact in patients' lives. Talk to me about some of your success stories. Tara, I know you are really new to this, so you may not have as many as Jason does, but I know that you've seen how this program works. So
Yes.
share some of your success stories.
So, a simple success story. One of he said, my aha moments is finding resources. When I come in and I was kind of looking at what they called quick fixes, I realized that those quick fixes aren't so quick if you do not have the resources behind it. So we actually got a lift assist call in the middle of the county, and Jason and myself went out there. We took that call so the crew could stay in service. And while we were on that call, Jason was like, "Man, this wheelchair ramp is just amazing." And he was talking with the family, and he was like, "Who did this for you?" And so that company or that establishment was Building Bridges. And we got through our software, the crew referral. They can tell you needs of certain patients. And it was hey, this patient needs a wheelchair ramp. Are you willing to be able to do that? So at that point, I contacted Building Bridges, and they were very efficient. They called. They were willing to go out to the patient's house, and that patient had a wheelchair ramp in less than a week.
This may sound like a stupid question, but talk to me about the impact of a wheelchair ramp, because it seems like kind of maybe a simple thing to some people, but talk to me about the impact that makes in a person's life.
It can make a huge impact. It differentiates with, do you stay inside or do you get to go outside? If I don't have the people and the support system around me and I live alone, then it's possible that I'll be stuck inside my home if I don't have a wheelchair ramp or somebody, to assist me with that. And then it's how many steps do they have? And that becomes a fall risk. So we don't need people falling and getting injured. So if we get that wheelchair ramp, it can make a difference with their health as well.
And I think not only kind of to continue along with that's an outreach portion of what we're able to do, but that it originated from a 911 call, and if folks need a wheelchair ramp, that means our crews are having to go into that house, potentially lift that patient out of that house, but potentially lift that very heavy stretcher into that same structure, and then back out with that patient on it. So, and again, it's a safety issue that it goes back for our crews and for our people.
Besides wheelchair ramps, what are some other needs that are being met?
Sure. Other needs that we see a lot of is fall risks. So folks we go inside and do the home safety evaluations, and we notice that, folks need assistance when they're in the bathroom or potentially in the kitchen or such. Sometimes they need handrails that are placed in specific areas. A riser for the commode so they're easier to sit back down and to get up from. Some of the 911 calls and the referrals that we've received, folks don't have proper medical equipment to be able to ambulate through their home. Need walkers or a cane or maybe, a wheelchair, so to say. So there's quite a bit.
And Jason, just because you and I have spent a lot of time together over the last year,
we have, Paige.
I know you've had a success story where you were able to provide a walker, and maybe I may have my patients mixed up, and maybe medication for a patient. You were able to do both of those things. Tell me that story.
Sure. It was, we identified a particular patient from high utilized 911 and then from crew referrals. I identified this patient. They acknowledged and accepted me to come visit with them for the first time. So it's a pre-encounter, we call it, and then the actual encounter when we go visit. So during the encounter, I did some research prior to it, and I learned that day that I was meeting with her, it was actually her birthday. She lives alone. She's been by herself. She has one family member. So I went, did my encounter with her, and learned that she needed assistance in her one-bedroom apartment, and she requested a walker. Well, another one of our partnerships was with Yokefellow. I was able to get a walker donated from them, and I bought her a balloon and took it back to her apartment and was able to give that to her on her birthday for our first encounter. So she was very appreciative of that, and it's small steps. We've still got a ways to go, but
Well, you say you have a ways to go with that patient, but some patients actually complete your program.
they do. They do.
How many patients have completed the program?
Right now, to date, so from July 1st until today, we've had 13 that we have deemed completed. Now, some community paramedic programs, they actually graduate. Some are more hospital-based where they have a 30, 60, 90 days where they have that time frame to graduate from the program. We deem them completed, meaning they become so idle that they don't need assistance, or we've met those goals in our action plan that we've set forth for them. So they're completed. That doesn't mean that they can't come back into what we consider active. So completed just means that they are so idle that we can move on and assist the next folks in our community.
For an active patient, how many times do you visit them routinely? Do you have a set number of times, or is it based on every patient's different and that's how you decide?
It's a good one there, Tara.
So I base mine on the patient need. Like you said, every patient is different. I have one in particular who is very compliant. She has a strong social network around her, so I see her maybe once or twice a month. And the reason that she was referred was she kept falling. The crews were having to go out to help her pick her up. But turns out, we're working with those issues, and she's got a strong social support. So I only see her a couple times a month. And then I have others that will call me multiple times in a day sometimes just to talk, just need an ear. And then I usually try to see them at least once a week at a minimum. It just depends on whatever need the patient has. I have a lot of mental health patients as well as a few substance abuse patients.
And I think it's important to point out now that you don't have set requirements for your patient. There's no age limit. Because we see a lot of programs that you have to be 65 or you have to be 55, but you don't have that. You base this on referrals.
We base it basically more on the high utilizer, because that high utilizer is going to be the one that's taxing the crews, the recurrent calls back to the home and such, where we can come in and potentially make a difference and redirect some of those calls. Those calls, and I deem those calls that go directly to my phone or to Tara's phone, that wasn't a 911 call, that they needed a help for an anxiety attack. Those types of calls, and those are the reasons, and those when we're able to touch folks that way, where they can call us instead of dialing the 911.
Right, and you're looking at people who dial 911 who may not need a transport to the hospital.
Correct.
Really,
Yeah.
that's who you're looking at. I don't want to say misuse of 911 because they have a need.
Correct.
But maybe an ambulance crew, those paramedics, is not what they need.
That's right. Yep. There's in mobile integrated health, it's there's a concept called ET3, which is your triage on scene, treatment, and then alternate destination transport. And that's ultimately going to be a goal of ours moving forward. Hopefully, again, we're in that crawling stage. That's at the running stage. But yes, there will hopefully eventually we will be to the point where Tara and I can transport those folks that don't need that. The traditional role of EMS is something is identified, 911 is called, an ambulance shows up, fire service, law enforcement, whichever it may be. And if the ambulance shows up, then you're going to go to the hospital. When, like you said, we don't all need hospitals. Sometimes we have the behavioral folks that need that assistance. Some folks need to get their prescriptions filled. Some folks need, they just need an X-ray, and or they have flu-like symptoms, and this whole COVID pandemic time frame, there was, urgent cares and folks were not allowed, we're not seeing folks as readily. So, that was a time frame where we could potentially step in and transport to those alternate destinations.
To add on to Jason's, is you take the 13 that's been completed. It sounds like a small number, but what the community needs to know is just by having those 13 patients completed out of that CP program, that's saved several hundred 911 calls that would have been made. Instead, they're calling Jason or Tara or Blake when he was in the community paramedic position, and they're getting resources without having to call 911 and then go to a hospital, and it just continues to be a spiral and they never get help.
Because in their mind, it is a true medical emergency, even though as a paramedic and a provider, you go on scene and you're like, this is not a true medical emergency. They do not need an emergency room. But in their eyes, it is, because they have no way to navigate the resources. They don't know where to turn to. So that's our job. That's where we step in and try to help them navigate the resources and get what they need.
And when you talk about a high utilizer, define that a little bit for a layperson.
A good example I can give you is someone that has like a frequent fall. We get dispatched out to the residents for just lift assistance. They need help getting out of their chair, going to the bathroom, and they're calling 911 to do that, where they're truly not hurt, or they're falling in their house. They're tripping over maybe rugs in the house, or their carpet, or their floors are too slick and they're tripping over it, and they call 911 to have lift assist for us to come out there and get it. After several, they keep a running list, or a running log, I should say, of patients, and once it hits certain numbers, they start noticing they've called like 5, 10, 15 times here in the last month. Then they'll actually make a visit out to go and figure out, see if they can find out what's wrong with them. And a lot of these can be corrected on the first and second visits. They can notice like, hey, you need, to grip socks instead of walking around and you're just slipping in your house, or this rug's causing you to fall. Let's move this rug, or let's tape it down, or let's do something to fix this issue. And it can usually be fixed on the first or second visit.
As chief, what does community paramedicine mean to the department?
It saves ambulances for true emergencies. We have in the last several years, we've had a dramatic increase in 911 call volume, which we can, of course, relate that somewhat to COVID this year. But, I mean, we need to keep all the 911 trucks in our county for 911 calls for emergencies. And by having a community paramedic program, they utilize, or they find the individuals that are calling 911, not because they have an emergency. It is to them, but it's not like that meets the true definition. They might just need help out of their chair, or like I said, or going to the bathroom, where we can send the community paramedics out there. They can get them the proper resources, and we don't have to send an ambulance out there to the residents.
Again, we implemented the program, we're calling it the pilot phase. We implemented it on July 1st. That's when we went live. But Blake and I were quite busy those months leading up to it. So for the months of May and June of 2020, the high utilizer group that we identified out of those calls, so that was 10 patients for Blake, 10 for me to start out with, and that's still where we are. But for May and June, we had a high utilizer groups. The total amount of 911 calls was 109. So it was 109 calls for those 20 people there. For that same 20 people, the two subsequent months for July and August, that number was reduced to 35. So that's a 74 call reduced just on those patients that we've identified and we were able to contact and touch. For September and October, we had a different number, same 20 amount, but it wasn't not necessarily the same number, but the high utilizer group, as we're calling it, we had for September and October of 2020, they were identified of using 911 for 89 times. And the subsequent months of November and December, the same folks dropped to 25 calls. So that's a 74 call reduction in 2 months, and then a 64 call reduction in the following 2 months for that same number of people.
You have talked a lot about organizations stepping in to help. If there's an organization out there, well, first let me ask this. What kinds of help do you need from organizations? What kind of help are you looking for when you go to a patient's house? I know it's different for every single patient, but is there some commonalities?
What do you think?
So one thing that I've noticed was the wheelchair ramps and the handrails. That was a huge need. And then something as simple as when the aha moment, when I had that aha moment was when a crew said, this patient needs a non-slip mat because they keep falling. When they get out of their bed, they need a non-slip mat right there at their bed. And I'm like, okay, how are we going to get this non-slip mat? So it's something as simple as that. And I would like to even in the future, because riding with McDowell, it opened my eyes to the homeless population. And those guys, some of them even carry like a tent and a sleeping bag in the back of their vehicle. So in the winter months when they go out and they see these homeless people walking and in need of a shelter, they're like, here. So people that can provide, or companies that can provide those type of resources for us would be a tremendous help.
While we're on that, if someone wants to build wheelchair ramps or provide resources, or at least have that conversation with you, how can they do that?
Sure. So we have our personal emails, but I'll give us the CP program. So it's Caldwell CP Program at caldwellcounty.org. That'll come to both Tara and I believe to Blake as well. So we'll all be able to see that. We can put that on the screen for you.
Okay.
As well.
I'm not going to let you go before I ask this, and I feel like Sierra sat down there like this whole time, just smiling, being really quiet. So, why CP? Why the Community Paramedic Program? I'm going to add that's for all three of you because I can tell, as Jason and Tara have both talked, it's something you're passionate about. So, why change your focus, so to speak?
So, it seems cliche, and a lot of stuff that I'm probably going to say seems cliche, but I genuinely love helping people. And I love my job as a paramedic. I love running 911 calls. But you do have these people, and they can attest to it. The majority of the calls are not true 911 calls, where you get to do all of your fun stuff that you've been taught in paramedic school. You're just helping them up off the floor, or little things like this, not necessarily a 911 emergency call. And me being the person that I am, I want to make sure I've done what I can for this person. I've literally, got a glass of water for somebody, or made somebody a sandwich if they wanted to before, returning back into service. And it's just stuff like that. On the 911 side of things, you don't have that time to really help. And you do recognize needs for patients that you can't do during the 911 side of the 911 side. So that has really kind of driven me. I was very, very interested in the actual program itself whenever it first come about. And I was just like trying to figure out, make sure this is, a switch, because this would be a switch for me, And that's just something that I've been passionate about. And then learning more about it, them getting it up off the ground and running, just seeing everything that they've been doing, it just seems like it's right up my alley. It's something that I'm, really, really interested in. And it's something that's not just going to be stagnant. I mean, it's always going to be growing. It's always going to be, furthering the program itself, and just ultimately helping people. It's really, really the reason why I like to do it.
Jason?
I'll echo a lot of what Sierra said, for sure. If we didn't get into pre-hospital medicine to help people, I guarantee everybody did. But the best thing I think I enjoy is that I'm able to spend a lot of time with these clients. Like, I know their animals' names, I know their family, we're able to spend time with them and to get them to know them more than just 20 minutes or a short transport time to the hospital. It's very easy for us to follow up. We can watch their continuation of care, from the care in the field through the hospital to if they need physical therapy, if they need rehabilitation, if they need skilled nursing facility placement. We can help facilitate that. And that we're progressing paramedicine. We're making paramedics rise to the cream of the crop, which we will be. Recently, in some classes that I was in, there are folks in Canada that are community paramedics that they are almost physician assistants in prescribing medications on the scene, doing suturing, doing out of hospital skills and skill set that is advanced. That's kind of a goal. Blake and I, when we came off the truck, we talked about it. Advancing our practice, advancing what we're able to do, is going to be a great long-term goal. But our skill set as paramedics, I joke a lot of time. My sister's a nurse. I love you, Jen. But when nurses are on scene there's a lot of times where the hospice nurses and such, where they need help and they need assistance, who do they call? They call 911. And that's where we come in as paramedics. That we have standing orders, we have things that we're able to do that are a different scope than a lot of folks. So we get to do the 911 side, and then we also get to do some of the clinical aspect as well. So,
Tara?
So this has been a huge change for me. Being on the truck for 14 years on the 911 side, and having the opportunity to be in leadership. As Jason said, he knows his patient's dog's name. He's very familiar with them. Well, our high utilizers, even as a supervisor and on a 911 truck, there's certain residents I would go in, call the patient by name. Hey, where's such and such? Where's your family? Where are they at today? Because I had that relationship with them at that point. But this allows us to even go in even more and get to know them even more. And like Sierra said, you don't have a lot of time as far as being on a 911 truck to sit on the scene and figure things out. This way, we are more of an investigator. We search out exactly what it is that they need. And I have always been passionate about my patients, and I was that person that would harass the ER, call them back, say, hey, how's this person doing? Are they all right? What's going on with them? So I've always had kind of, a servant's heart, and that's what really attracted me to that position, because I knew going into this position that some of the homes that we might go into may not be the cleanest or most immaculate, and that's okay, because that's the people that need help, and that's the people that I want our county to reach, in this program to reach, is those that have been forgotten. That's the ones that need the help the most. And
I haven't asked about COVID, but I know there's some extra outreach you're doing with COVID. You want to talk a little bit about that?
Sure. We, in a collaborative approach to the COVID response, we were in the EOC, obviously, Paige. We got to spend quite a few hours together there with Blake and Jonathan as well. But with that, we were a part of the decontamination teams that were going and doing that, staying 24 hours to decontaminate the ambulances for the crews. Not only that, now that we're kind of on the downward slide of that, which is knock on wood, we're currently collaborative with the health department. We're going out and giving and administrating the vaccines as well, the COVID-19 vaccines. As they're requested by the health department, we're able to go do that, folks that are bedbound and such. So just another way to, I use it all the time, and all of my students, if you're listening, you'll know, we're boots on the ground, and we are literally those ones that are out there doing. We're in the homes all the time. So why shouldn't this just be another, feather in our cap, being able to help the community?
Well, thank all of you for taking time out of your day to join me. I want to ask, have I forgotten anything? Is there anything anybody wants to add?
I think, like Jason said, pretty much the focus on the CP side is going to be progressing down the road with advanced care practice, paramedic, because EMS pretty much is moving in that direction. Everything in the future is going to be advanced practice paramedics. And the biggest thing with us is you can't progress without reverting back to the basics, which is building that relationship with the patients, getting to know them. So I think that's a big thing for the CP side.
And this just popped into my head, so here comes one of those super random questions. Counties around us with community paramedic programs, do we have any, and who are they, and where are they in this process?
As Lieutenant Powell said, we do. We try to model off after McDowell. They're really progressive. They've been around for almost 7 years. Is that right? Yeah, 7 years. There's really no cookie cutter program though for the CP side for your community. So we've kind of developed ours and made it fit for Caldwell's needs. But it's definitely, there's a few around that are actually pretty much in there already.
And again, if there are organizations that think they can provide a service that would benefit the community paramedic program, what's that email address?
Caldwell CP Program at caldwellcounty.org.
Okay. Caldwell County NC.
NC. You know what I meant?
We'll put it on the screen.
Put it on the screen.
Put it on the screen.
We'll put that on the screen. Thank you all for joining us.
Thank you for having us.
Thank you.
Thank you.
Thank you, Paige.
Thank you.
And thank you for watching Caldwell County Today.